Hi everyone and welcome to the another session on the upper limb. I'm Dr. Ankit, your faculty of anatomy in our Auricle platform. So guys, why to choose Auricle? Here we can see a lot of benefits for joining Auricle, and you have really all the features. We have from recorded classes, live classes, to practical sessions, exam modules. We have rapid exam modules to hard copy book set. I'll show you some of the slides over here, starting the foundational classes, a live express exam module, doubt clearing session, very important. Hard copy note set, the Q bank, practical sessions, very important. And these are all the subscription plans. So we have from 3-month plan to 6 months plan to an year plan to around 4 year. Here the costing is all written below, and you can use this code below, Dr. Ankit 20, to get some discounts. Right. So the code is Dr. Ankit 20, get some discounts. Okay. Fine. So coming back to our topic. If you have not gone to a previous topic, you can go to the upper limb part 1 topic. There you can see what we have covered in that topic. Right? Okay. Just a second. Right. Let me just pick up the pen over here. Right. So this is an upper limb part 2. And these are all the topics or the questions, or we can say the short and the long questions that we are going to cover. So a brief idea is what we have covered already. Let me use a highlighter over here. Just a second. Correct. Yeah. So here a long essay question. Provide a detailed description of the brachial plexus over here, including its formation, branches, clinical significance, especially in relation to the common injuries. Okay. So this is one question or one topic that we are going to cover. Next, we can have a discuss the arterial supply of the upper limb. So we can talk about the arterial supply, focusing on the major branches and the clinical importance. So arterial supply is the other topic that we are going to cover. Let me tell you that brachial plexus is something that we have slightly touched on in our previous session, just a couple of days back. And arterial supply. Then around the shoulder joint, we can, as I told you previously also, that of all the joints, it's the shoulder joint that is most frequently asked in the theory exam. So explain the anatomical structure of the shoulder joint, including the muscles and ligaments and their relevance to the shoulder dislocations. And the question could be outline the arrangement and functional importance of the radial and ulnar artery. So again, it comes under the arterial supply, right? So we have if to begin with, we have a brachial plexus, we have arterial supply, and we have a shoulder joint over here. Next, some small topics like short answer questions. Though we have covered it, is just showing you what is the rotator cuff and why is it important. So rotator cuff, if I just tell you over here, SI small t and S sits for the mnemonic. Describe the carpal bones. We discussed the mnemonic over here, right? If you remember, she looks to pretty tight to catch her, and the arrangement. Then another short question, explain the significance of the anatomical snuff box. If you remember, if you don't, then please go and visit the previous video. We have discussed the anatomical snuff box, ASB, all the boundaries, the roof, the floor, the content, everything over there, and potential clinical concerns. Okay. So these are three major topics that we are going to cover. The brachial plexus, though we have touched upon it in previous session, but still we'll do it. The arterial supply and the shoulder joint. Okay. So without wasting any further time, let's begin with. So here is the first one. Provide a detailed description of the brachial plexus. Just a sample question over here, including its formation, branches, and clinical significance, especially in relation to the common injuries. Okay, let me switch on to the pen mode over here. Okay, so here we go, right? So brachial plexus. Brachial means the arm and plexus is the plexus of nerves. So let's begin with over here. I just try to take a little bit back, making you understand what actually was the axilla. Because brachial plexus actually is located in the axilla, right? So axilla is what? Here we have started with axilla. Axilla is a pyramidal region between the upper thoracic wall and the arm. So this is the upper thoracic side. This is the arm. This part of the body over here, between the thorax and the arm, This is the axilla. It's a pyramidal region. Here you can see this green shade area. That is our axilla. That is our axilla. Now, axilla itself is a question in itself. Here, question can come regarding the boundaries of the axilla or the contents of the axilla, right? So we can go with it. So we have this axilla over here. So what does the axilla basically constitute of? It's a passageway for the neurovascular structures to serve the upper limb. So what is the neurovascular structure that serve the upper limb? Neuro means what? Brachial plexus. So will it serve the upper limb? Yes, all the muscles in the skin. Vascular means what? The blood vessels, that is the arteries, the veins, and the lymphatics. Correct. So all this nerves, artery, vein, lymphatics, they actually pass through the axilla. If you can see in this image over here, here we are seeing this blue colored vein, red colored artery, and the yellow colored nerves. So these are the neurovascular bundle. These are the ones that are actually passing through this shaded area, that is the axilla, from thorax to the arm or arm to the thorax, right? That is the axilla. Contents of the axilla. So this comes as a separate enumerated question. We have seen the axilla over here, this green shaded area. What does it constitute of? Artery, correct. Vein, correct. Lymphatics, correct. So that is the vascular part. If you understand, then that is the vascular part. Okay. Then here the brachial plexus, that is the neural part, neurovascular. Right. Proximally, these neurovascular structures are ensheathed in a sleeve-like extension of the cervical fascia, the axillary. That is another question. Axillary sheath over here. Now, so what is that question? Now listen to me carefully over here. Question comes in both the formats regarding your theory, Viva or MCQ about around the axillary sheath over here. Axillary fascia is different. Axillary sheath is different. Axillary sheath is actually a sleeve-like sheath over here of deep fascia. Now that is coming from this part of the cervical, that is the neck region, cervical fascia. Okay, so we have axillary sheath that has the nerves and the vessels. They are coming from the cervical fascia. A question has come in the previous that which part of the cervical fascia. Now here, let me tell you, it's a deep cervical fascia. Obviously, it's a deep cervical fascia. Which part of deep cervical fascia? Listen to my lines very carefully. The axillary sheath over here, it is derived from. It's a very famous MCQ. They will tell you because all the MCQs are actually coming from the important topics. Understand that. So the axillary sheath over here comes from a deep fascia, that is your prevertebral fascia. So please note down this in the form of your notes. Prevertebral fascia, star mark. Axillary sheath is derived from prevertebral fascia. So all these are the contents of axilla, the neurovascular structures, and these structures are embedded in fat and aerial tissue. Fine, that is okay. Okay, let us move forward. Now, to begin, before the detailed brachial plexus, we have over here a course of a typical spinal nerve. Now, what does that mean? That means that you can see there's a transverse section of the spinal cord over here, right? Having the anterior roots and the posterior roots over here. Okay. Now, this spinal cord, when we say, or spinal nerves, when we say, we actually mean all the 31 pair of spinal nerves, which includes the cervical, the thoracic, the lumbaral, the sacral, and the coccyx over here. The lumbar, sacral, and the coccyx over here. So we have 31 pair. Here you can see that from the ventral or the anterior root, we have this red colored anterior root that are coming, and they go through this sympathetic trunk, or they may go directly. And then we have this blue colored afferent over here, which will actually go through this dorsal root ganglia, and finally they go into the dorsal root of the spinal cord over here. Okay, and then we have the interneurons over here, by which we can. This is the same actually of all the nerves. So here, why we have shown this diagram over here? Because we are dealing with brachial plexus. That is C5 to T1. Previous session, I again say go back to previous session. We'll discuss here. In the previous session we touched upon this topic here a bit in detail. Next, see over here the brachial plexus root value. Let me tell you, it was normally it is C5 to T1. Though C4 can contribute, T2 can also contribute. If a C4 contributes, we call it as prefixed. If T2 contributes, we call it as postfixed. Here you can see in this image over here, we can see this bone clavicle. We can see this yellow colored nerves over here and over here also. So these are, that is above the clavicle, these are regarded as a supraclavicular, as you can see over here. Let me use a highlighter over here. Here we go. Yeah, you can see the supraclavicular over here. And below this clavicle, you can see all this infraclavicular nerves. These are all infraclavicular. So above the clavicle, we have the supraclavicular area. And below the clavicle, we have this infraclavicular area. That is all in this whole description over here. Got the point? We have other images also. But now when the question comes, right, you should know that what we discuss. This is a sort of diagram or image that we can actually make, right? This is a sort of diagram that you can actually make. It's a line diagram. Okay. You can make this simple by your blue colored pen, black colored pen, or if you took, then yellow color will be the best. If you start with, we have these roots over here, then we have the trunks, then the divisions, cord, and the terminal nerves of the branches. If for you guys who have gone through my previous session, this over here means, if I tell about the mnemonic, write to, D for division, drink, C for cords, chilled, and this is terminal nerves or the branches, B for beer over here. Branches, B for beer over here. But this diagram is mandatory. If a question comes from the brachial plexus, no, not if. Let me tell you over here. To be honest, I have been a faculty of various medical colleges. I have been checking question papers in the last decade or more than a decade actually. Whenever there's a question, whenever there's a paper on the upper limb, whenever there is a paper on the upper limb, more than 90%, it is obvious that a question from the brachial plexus will definitely come. How much percentage? More than 90%. I am sure about it. Mark my words over here. More than 90%. So therefore, if you are by far giving a paper where you have the upper limb as one of the topics over there, this topic, brachial plexus, is the most important topic from the entire upper limb. Well, it has 9 out of 10 chances to be coming in the exam. So this sort of diagram, you have to make it. You have to practice it. From C5 to T1, you have to make roots over here. Then you have to make 3 trunks. Then out of 3 trunks, you have to make 6 divisions. You have to make 3 chords, and then you have to name some of the important branches over here. That is actually it's a mandatory over here. Okay. Then supraclavicular branches over here from roots, because if you see in the previous images, supraclavicular part is root and trunk only. So root and trunk, these two comes under supraclavicular part. If I may use a highlighter over here, this is supraclavicular part, that is root and trunk, right? So we have the supraclavicular branches over here. These are branches from root and the trunk. Now, when we say root, we have how many roots over here? We have 3 roots. Oh, not 3, but we have 5 roots from C5 to T1. But they are making 3 trunks over here, superior, middle, and inferior. So if you talk about the branches of the roots and the trunk, mainly trunk, when we say we have the upper trunk, as we can see below over here, we have the upper trunk. Then we say branches from the roots. Basically, for the upper limb part, these 2 branches are very, very important: dorsal scapular nerve and long thoracic nerve. And when we say branches from the trunk, it is basically the upper trunk. Then we have these 2 branches, that is nerve to subclavius and your suprascapular nerve. So these 4 are the main branches that we have to deal while dealing with supraclavicular branches. Now, what do they supply? Coming to the practical standpoint, see this dorsal scapular nerve, it's going to supply the which muscle? Levator scapulae muscle. It's going to supply rhomboideus major muscle, and also it's going to supply the rhomboideus minor muscle. The long thoracic nerve is going to supply the serratus anterior muscle. The nerve to subclavius is going to supply this muscle only. The suprascapular nerve over here is going to supply the supraspinatus muscle, and it's also going to supply the infraspinatus muscle. Make sure about it. These are all the branches from root and trunk. That is the supraclavicular branches over here. Clear? Next, we go ahead. We have this ups point. Ups point is where the upper trunk. This is the C5, C6 root over here. We have this upper trunk. So upper trunk point is known as ups point. So any injury over here leads us to which palsy? It's the ups palsy. It's the ups palsy. We focus on this pinkish colored circular highlighted area over here. We have 6 nerves. 2 are the roots, C5, C6, right? And then from these roots, right, what is formed is the upper trunk. Upper trunk has 2 divisions, the ventral and the dorsal. Okay, and upper trunk has 2 branches, seen the previous slide, nerve to subclavius and suprascapular nerve. As you can see over here, this is nerve to subclavius, and this contributes also to this supraclavicular nerve over here, or suprascapular nerve over here. As you can see over here, this one going to suprascapular nerve. So these are 2 branches of what? Upper trunk. So Ubbs point has 6 nerves, 2 roots, right? 2 divisions. Divisions are divisions from the upper trunk, and 2 branches from the upper trunk, subclavius branch and going as a suprascapular. Am I clear? 2 divisions are ventral dorsal. I'm not going in detail because I hope we have gone through it. That each trunk will have 2 divisions, the anterior and the posterior, that is ventral dorsal. Then out of these 6 divisions, we have 3 cords: the lateral, the posterior, and the medial. The posterior is the largest one over here because it is contributed by all the posterior divisions of the 3 trunks. Okay. Okay, let's move ahead. So we have seen the ups point. Okay. Here's another image showing us. See the sort of images over here. Let me tell you beforehand. This image, what you're seeing right now on your screen, it's a mandatory image. We have to draw it. Then all the branches you have to write. You can again draw something like this, and you can talk about the ups point. You will see the ups. I'll see in a while. Then these are the infraclavicular branches. See, right to drink a chilled beer. Root and trunk was supraclavicular. All this is infraclavicular, but division has no branches. So what are you saying? Yes, I repeat myself. That division has no branches. Division has no branches, right? So then we have the cords and the branches. So out of these cord and branches, these cords over here, these are the ones which are going to have branches. All these cords branches are infraclavicular branches. So in another way, if we can say, then we can say that the infraclavicular branches are the branches from the cords. How many cords we had? Lateral, medial, and posterior. Lateral, medial, and posterior. So we can see over here the branches from lateral cord, medial cord, and the next slide will show us the branch from the posterior cord. The branch from the posterior cord. Sir, how to remember them? No problem. Lateral cord, the mnemonic over here would be LML. LML. Lateral pectoral nerve, L, musculocutaneous M, and the L is the lateral root of median. Yes or no? That's a very simple way to remember it. Okay. So LML would be the branches from the lateral cord. Middle cord, the mnemonic is your M4U. That is 4 times the M, and 1 single U over here. So here 4 times the M, you have 1, 2, 3, and 4 over here. 4 times M, right, and a U, that is for the ulnar. So M4U, let me highlight this for you guys. M4U would be the mnemonic for branches of medial cord. And LML would be the mnemonic for branches from lateral cord. Finish. What do they constitute? That you have to remember. Okay. You can't do anything over here, you have to remember. Okay, right. Just a second. Right. So LML is a mnemonic for the branches from the lateral cord. And then we have M4U is for the mnemonic for the branches from the middle cord. Okay. We had three chords. Third chord over here is the posterior chord. Here you can see the mnemonic over here, ultra. U for the upper subscapular, L for the lower subscapular, T for the thoracic. What is the thoracic? Also, let me tell you over here, each muscle which they do supply. Thoracodorsal, R for radial, and the A for axillary. So these are five from the posterior cord. How many branches? Five from here. Middle cord, how many branches? Five from the middle cord. Lateral cord, three from the lateral cord. So total, we have seen the previous session also. That 13 branches are there, right? Right. So 13 branches we have from all these three cords over here. All these three cords over here. What do they supply? Understand this. Let us go one by one. Lateral pectoral nerve, let me use a highlighter over here, will benefit more. Lateral pectoral from the lateral cord and medial pectoral from the medial cord. They both will supply what? Which muscle? Very simple, a pectoral muscle. Simple. Then lateral root of median and the medial root of median. What will they make? Medial nerve. Finish. Keep it simple, right? Then we have cutaneous branches of arm and cutaneous branches to the forearm. They will supply what? Skin sensation, pain test temperature. Finish. Now what we are left with, understand, things become so simple. We are left with only two nerves, musculocutaneous and the ulnar nerve. What do they supply? What do they supply? Think about it. The musculocutaneous nerve supplies the anterior arm muscles. And it has a cutaneous part. It supplies the lateral cutaneous nerve of arm. Previous session, we have discussed it. We're just revising that small part. Things overlap. And therefore, that revision, it helps in your consolidation of the knowledge. So musculocutaneous, the muscle part will supply the anterior arm muscles, which includes the biceps muscle, the brachialis, the coracobrachialis. And the cutaneous part is the lateral cutaneous nerve of the arm. Okay, one more left is ulnar nerve. Ulnar nerve over here. Let me tell you about the ulnar nerve. Okay, just a second. Here we can write about the ulnar nerve. Ulnar nerve is the main nerve that supplies the muscles of the hand on the hand, palm area. It also supplies 1.5 muscles in the forearm. 1.5, sir, yes. What is 1.5? One over here is the flexor carpial nares, and half over here is the medial half of flexor digitorum profundus. So it's 1.5 muscles. In hand, does it supply all the muscles? No, it supplies majority of the muscles. Around, we can say 3/4 of the muscles of the hand is supplied or are supplied by the ulnar nerve. Right? So from this lateral medial cord, we have come through what do they supply? Posterior cord, we have upper and lower subscapular. They will supply which muscle? Sir, subscapular means subscapular is done. Thoracodorsal nerve. So what does it supply? Is it a cutaneous nerve? No. It supplies a muscle. Which muscle is that? That is latissimus dorsi muscle. That is latissimus dorsi muscle. Then we have a radial and axillary nerve. The radial nerve over here, the radial nerve is the largest branch of brachial plexus. It is the largest branch of the entire brachial plexus. But sir, what does it like? What is the radial over here? The radial actually means that it is supplying the posterior part of the entire arm and forearm. Sir, what do you mean by entire? By entire, I mean supplies the skin as well as the muscles. Okay. Therefore, it is the largest part. Understand that. When a question comes on which is the largest branch of brachial plexus, it is the radial nerve. Okay, sir, done. Sir, I can try to digest that. Last is left. So what about the axillary? What is the axilla? Axilla, we have seen, sir, what is the axillary nerve? Previous session. For those who have gone through the previous session and revised it, it supplies two main muscles. What are those? The deltoid and teres minor. Deltoid and teres, what the minor? That's it. That's it. If I ask you, that's a question which I gave you to answer me in the comment box. I am not going to answer that. What is that? Axillary nerve has a cutaneous innervation as well. Which one? So what is, in the comment box, answer? What is the cutaneous innervation? What is the cutaneous innervation of axillary nerve? So that's very important clinically as well. Okay, in the upper limb, in the entire upper limb. Where does the axillary nerve supplies the same sensation of the upper limb? That is the question for you. I'm looking forward, though I don't get so much of responses in the comment box, but I'm looking forward to this time for you guys to answer me. Whoever is watching this session live or later on, comment box answer. The cutaneous innervation from the axillary. Let us see. Okay, now coming to the brachial plexus injuries, we have a couple of them we have discussed, but this will go through again. So injury includes the cutaneous involvement as well as your muscular involvement, which will lead to the palsy. So it is to the muscle involvement, palsy, and cutaneous involvement. Okay. So we have to do all this test over here. Let us see more forward. So here is the obstruction palsy. We have discussed in the previous session. But just quick revision. So structure on the superior part of the brachial plexus tears the roots of the brachial plexus from the spinal cord, and therefore that includes C5 and C6. This is the sort of area that we have discussed, the ups point over here that leads to ups palsy. And this is the mode of injury, falling, and then there's undue separation of the neck and the shoulder. So when there's so much of separation over here like this, no, so this is a stretching the entire upper part of the brachial plexus. Okay, in this sort of mechanism of injury, or when there is this excessive stretching of neck during delivery. Imagine there's a shoulder dystocia. The head has come out, okay, during the normal vaginal delivery, and the shoulders are actually obstructing the delivery. It's known as shoulder dystocia. In that, you have to slightly manipulate the neck region. In that cases, there can be excessive stretching that will lead to the ups palsy, where we have the superior part, mainly C5 and C6 is involved over here. Simple as that. So this is a waiter strip of the policeman tip deformity. These are the sort of images that you have to make in your exams as well. Let me tell you this. Okay, because out of ups and clumcase palsy is much more common than the clumcase palsy. Clumcase palsy is for the lower trunk, and ups palsy is for the upper trunk. Upper trunk when you say C5, C6, lower trunk when you say then C8 and T1. How to remember it, sir? Because when you study ABCD, K to Z, then E comes before K, A, B, C, D, E, F, G, H, I, J, K. So E comes before, so it is involvement of the upper trunk, and K is involvement of the lower. So you can remember by this. This is ups palsy involvement over here. The three nerves, if you remember, I told you the three major nerves are remembered by the mnemonic SAM. That is, one is suprascapular nerve, M is musculocutaneous, and A is which one? Axillary nerve. The same nerve for which I asked you the question will be in the next slide, axillary nerve over here. Apply delta and TS minor. Okay. So these three nerves are involved in the, or are basically involved in the ups palsy. So whatever muscle do they supply, let me actually highlight it so that you know what is important over here. Supra and infraspinatus actions, they are compromised. Musculocutaneous, if that is involved, then biceps brachialis action is compromised. If you involve the axillary nerve, then deltoid and teres minor actions are compromised. So, but sir, what action do they do? Something you have, I'm sure that most of you know the answer. Just for the sake, let me tell you, this is involved in abduction. Infraspinatus involved in lateral rotation. We'll see in the shoulder joint part. Biceps involved in flexion and supination. Brachialis involved in flexion. The deltoid mainly involved in abduction, and teres minor mainly involved in lateral rotation. So these are the actions that will be compromised, and therefore this would be the presentation. So how to remember it when not getting the point? See, if abduction is involved, then arm will not be abducted, it is adducted. Yes or no? Yes. When lateral rotation is not being done, arm will be medially rotated. Is it medially rotated? Yes, sir. Okay. When flexion is not done, flexion of what? Flexion of the forearm basically, arm will be extended, or the forearm will be extended. Yes, sir, it is extended. Very good. When supination is not being done, then arm or the forearm will be pronated. Is it supinated or pronated? Sir, it is pronated. Very good. So all these actions are actually compromised. Therefore, this is the final output of the patient over here. This is obscency or Vater's or placement deformity. I hope you got the point. Okay, let's move forward. These are the mechanisms of injuries of the K for clump case, lower trunk involvement, CAT1. We have discussed previously. I'm not going to again the details of it. Having a clawing of hand. What happens? What is the mechanism of injury? Because this is something that the patient or the patient's relatives are going to tell you in the OPD or the emergency, mainly emergency. Someone was falling down, they caught hold of a branch of a tree, or it was a breech delivery, something like that. So, abduction of the arm, as in clutching something, or a birth injury. These things can lead to clump case palsy. Injure the inferior trunk, that is the lower trunk, as we are saying. They can be clawing of hand. It is characterized by all these things that we already seen what is happening in the clawing of. These are one of the most frequently asked questions. Okay. So this was all about the brachial plexus. I hope you understand this part. Let's move on to another important aspect of the discussion today, that is about the arterial supply. Though, sir, but we have touched. Yes, we have touched. We'll go a bit far from that. Arterial supply and about the radial and the ulnar arteries. So for those who are in this session, look at our previous session also. There we have touched. This is the entire arterial tree of the upper limb. Entire arterial tree. I hope this image uh, gets you have some basic knowledge of it. You can see this is a sternum over here. This is the humerus or the arm region. That is the forearm region. And here you can see a single artery. Can you name the single artery over here? The single artery. Yes, sir. This is this axillary artery. Yes, it is the axillary artery. So over here, we have the artery running in the axilla. That is the axillary artery. But from where it is coming, it is a continuation of this artery. So which artery is subclavian artery? What's the subclavian? Yes, subclavian artery is coming from the arch of aorta. So from the arch, this is the heart and this is the arch of aorta over here. It gives off the right subclavian over here and the left subclavian. So we have this left and the right subclavian. These actually, they become the axillary arteries. As you can see over here, subclavian becomes axillary. As it reaches the arm, it becomes brachial artery. So we have a single vessel going to the upper limb. Now, if something happens to this vessel, all the tissues in the upper limb, they will go dead, necrosed. Just imagine the importance of it. Imagine there's a single river flowing through a city. You have a river over here that passes through a city. If this river is blocked by any chance, there's a dam or whatever it is, this whole city which was dependent on this river will go dry. Okay? And obviously, starting from the animals to the humans, the the living things in this particular city will obviously find harder to survive. That is what happens in the upper limb as well. Because the artery over is nothing but a river. Why? Because it is carrying the nutrition, the oxygen, the food materials, supply all the tissues of the upper limb, including the bones, the muscles, right? The fascia, everything. The skin and even the skin, obviously. And if you block it, then therefore, what we studied in the previous session was the anastomosis around this bone over here. That is scapula. If not, then please go through. I will show the image. But this entire image shows us the arterial tree of the upper limbs. Here you can see how the brachial artery then divides into these two arteries. On the middle side, we have the ulnar artery. On the lateral side, we have the radial artery. Okay, so two arteries now. Very good. But then they will reach the hand region or the palm region. And here the body is actually reaching its terminal point. Here you'll see these some of the arches over here, which we have discussed previously also, but let me just tell you over here. We have two arches, a deep and a superficial palmar arch. For those who have gone through our previous session, we know that we had made a mnemonic. What was that mnemonic? Doctor was the mnemonic. So deep palmar arch comes from the radial artery, as you'll see. Okay, just to show you the entire arterial tree over here, then we can actually move forward and look at this MCQ. Again, this is a repeat MCQ for those who have visited or seen our previous session. Would find this MCQ very easy. Axillary artery has been occluded deep to the pectoralis minor muscle. Which blood vessels would most likely provide a collateral circulation around the blockage? Basically, anastomosis around AA is anastomosis around scapula, and the arteries over here are option number C, the subscapular and the suprascapular artery. Subscapular was coming from the axillary artery, suprascapular coming from the subclavian artery. Let us see that image again. This is the axillary artery divided into three parts, first, second, third part. By which muscle? By the P minor muscle. How many branches were there? First part had one branch, second part has two branches, third part had three branches, total 6 branches. Here are all the 6 branches. Let me highlight those branches for you, else you will get confused a bit. You might get confused. I'm not sure you will get, but you might. First part gives the supreme thoracic, number one. Number one means from the first part. Second part will give a thoracoacromial and a lateral thoracic branch, number 2. Third part will give a subscapular artery and anterior posterior circumflex humeral artery, number 3. 1, 2, 3 over here are first part, second part, third part. Total branches is 6 branches. This is our axillary artery, which passes deep to the P minor muscle. Here it is which view? Let me ask you guys over here. Think in your head. If possible, answer in the comment box. This is which view? Are we looking at an anterior view or a posterior view? The question isn't your coat, or the ball is in your coat. Which view it is? This axillary artery is actually a bit shaded. It means that it is lying in front of the scapula. If the axillary artery over here is lying in front of the scapula, which view it is? It is, yes, it is the posterior view. Here, basically anastomosis around the scapula is being shown, and let us again use the highlighter over here to show you the suprascapular artery, to show you the circumflex scapular and the anterior posterior circumflex humeral and the circumflex scapular artery. And this is your deep branch of transverse cervical, or you can also call it as a dorsal scapular artery. If we can use the pen over here, dorsal. Why dorsal scapular? Because it is running dorsally on the scapula, dorsal scapular artery. Simple as that. These are the ones which will anastomose over here. So if there's any tomorrow is there any blockage in the axillary artery, then we all know that the blood can be shunted directly from the subclavian artery into your brachial artery, and that can go down into the upper limb, so that the upper limb tissue don't die. The people in the city, they don't die from thirst. Water is reached from there, if not to the main river, then through the collaterals or through the smaller branches of the river. That is the whole point, right? Okay. Next question over here. All of the following are branches of the brachial artery except brachial artery is nothing but a continuation of axillary artery. Profunda brachia, is it a branch? It is a main branch. Nutrient artery to humerus, yes. Ulnar collateral, not sure. Common introitious, let us see. But ulnar collateral is a branch. There are 2 branches from the brachial artery regarding the ulna. One is a superior ulnar collateral, one is the inferior ulnar collateral. But common introitious is the answer over here. Let me highlight this because just for you to guys remember that this is the answer. The common introitious artery is actually a branch from which artery can be another question. It is a branch of dash artery. So this common introitious artery is a branch of ulnar artery. It is not coming as a branch of brachial artery, though ultimately the brachial divides into radial, ulnar divides into common introitious, fine. But directly, common introitious is a branch from ulnar artery, not from the brachial artery. That is the point over here. Okay, so can we see some image? Here it is. Okay. Kindly. Just a second. Okay. I hope slightly better now. So yeah, this is the image over here. So we can see the bones over here, the humerus, and these are the radius and the ulna. So this is a region somewhere in the lower end of humerus, or we can see the elbow region over here. Okay. Let me highlight the few points over here. Just give me a second. Okay, over here. If we go, so this you can see the brachial artery coming down. It's a continuation of which artery? Axillary artery. Now here, let me tell you first of all the 2 ulnar collaterals, superior and inferior ulnar collateral. Good enough. Brachial artery is also giving off over here the profunda brachial artery, as you can see over here, that this artery over here is the profunda brachial artery. Profunda means a deep artery of the arm. This will then give off some other branches, fine. But here you can see the brachial artery divides into a radial artery and a medially running ulnar artery. This ulnar artery gave off that was the question, common interosseous artery. The radial artery will give off other recurrent artery and all, fine. But this all over here tells us what? It tells us the importance of what? Anastomosis. Around which area? Around the elbow area. So here what we are witnessing is the anastomosis around the elbow area. But so which arteries anastomose with which other? That is a tough question to ask and answer, but I'll try to help over here. What we have seen till now is the brachial artery, its ulnar collateral branches. We have seen the radial ulnar artery and its common interosseous. Fair enough, right? We also have seen the profunda brachial artery as well. Okay. Now, anastomosis around elbow. Listen carefully. The brachial artery is giving off ulnar collaterals. The ulnar artery over here also gives off what? The anterior and the posterior ulnar recurrent artery. Now, which arteries anastomose with which? Let me try to show you over here that the superior ulnar collateral artery over here, it will go and anastomose with the posterior ulnar recurrent artery. Okay. The inferior ulnar collateral artery goes and anastomose with the anterior ulnar recurrent artery. The radial collateral artery over here, it anastomose with the radial recurrent artery. Okay. Right. The interosseous recurrent artery from here anastomosis with the middle collateral branch over here. So very hard to digest. I told you it's not simple. Understand this image. Try to draw this image multiple times. Things will get clear. This is one of the most, you can say, difficult questions that can come in your exams, right? And then you have to simply draw this image, right? And this is all about the anastomosis around the region of elbow. Okay, let us move ahead. Now here come to the hand part. Okay, we come to the hand part. As you discussed, the mnemonic was what? DR. So deep palmar arches coming from where? Radial artery. Can you see it over here? Let me just help you guys. Deep palmar arch, always remember it's lying where proximally related to the superficial palmar arch. So deep palmar arch, and let us see over here the radial artery. Follow the two yellow highlighted areas. Let me now change the color. That is how you can use the technology. Look at the superficial palmar arch and look at the ulnar artery, how it is contributing. Main contribution. It is not that the deep palmar arch is totally supplied by the radial artery. No. It means that the deep palmar arch, or the deep palmar arch, the main contributor, you can say the main contributor is the radial artery. Though both the arches, they get completed by both the arteries. Okay, just a second. So both the arches are completed by both the arteries. Understand this part. That be it your deep palmar arch, be it your superficial palmar arch, they will have contributions from both the radial and the ulnar, but it is only the main contribution of deep palmar arch is from the radial artery. The main contribution of superficial palmar arch is by the ulnar artery. Simple as that. So yes. And where are these located? You can see the thumb over here. If I just show you from my hand, this is the approximate location of my deep and the superficial palmar arch. Approximate location. Right? Similarly over here. And you can see the superficial palmar arches, they are giving branches that are going to the fingers, digits over here. And the deep palmar arch, this you can say orangish color over here, it's giving branches to the thumb. Which branch? Let me use the yellow highlighted part over now, right now. Just a second. Right. This deep palmar arch is giving off an artery going to the thumb known as princeps pollicis. Now, pollex means thumb. And one more artery going to the lateral side of the index finger known as radialis indicis artery. So if you have a bleeding from the thumb or bleeding from the side of the index finger over here. These are basically the arteries over here are coming from deep palmar arch. Now, sir, this bleeding, what does it mean? See, understand from a practical point. If there's a normal blood that is coming out, there you have a small cut and the blood is coming out, it could be a capillary bleed, or if there's more severe bleeding, could be a venous bleed. Some veins are damaged. But if the blood is coming with some pressure I'm saying, then it is most probably what? It is most probably arterial bleed. So we have to distinguish between a arterial bleed and a venous bleed. From the, if there is an arterial cut and arterial bleed, then the blood will come through pressure. Understand my point? Will come through pressure. There'll be a pressure, like, this blood will come in a quite a bigger speed, quite a high speed, compared to if there is a venous bleed. That will just be flowing down. Both cases, there is a loss of blood. But the speed of loss of blood is more in arterial bleed than a venous bleed. Understand this? Okay, tomorrow you will get some patients. Understand this point. This point that in an entire body, if it is an arterial bleed or a venous bleed, because patients and their relatives will get panic obviously when there's bleeding from any part of the body, even be it fingers. You have to judge whether it's which type of bleed. Why? But if it's a venous bleed, then you can simply give them instructions to don't panic, simply compress it for a few minutes, things will settle down. But if it is an arterial bleed and you diagnosed that it is an arterial bleed, then you yourself has to take some measures to correct it. Else simply by pressing it won't normally treat it. So arterial bleed, you have to be a bit more cautious. Okay. Okay, what is that design? Yeah, this is an angiogram over here showing us both the arches. It's an angiogram. You can say the palmar angiogram. We can see the deep palmar arch as well as superficial palmar arch. Remember, superficial palmar arch is a couple of centimeters, or at least 1 to 2 centimeters, somewhat 1 to 2 centimeters, 1 to 2 centimeter distal. It is 1 to 2 centimeter distal to deep palmar arch. And remember this. Right, now talking about the veins over here. Veins are not that much important for the upper limb, but still you can touch on it. You can see this cephalic vein and the basilic. The basilic vein lies medially in the arm region. Cephalic vein lies laterally in the arm and forearm. Here we can see this is the dorsal venous arch, that is the back of the hand over here. These you can always see a lot of veins over here. Okay, and from the thumb side, that is the lateral side, we have the cephalic vein. Middle finger, that is the little finger, we have the basilic vein. Therefore, basilic vein runs medially. How did I remember? Let me tell you. When we see A, B, C, no, B comes before C. Therefore, B is more inside. B is more medially. That is basilic vein. B for basilic vein is more medially compared to C, that is more lying laterally. What is C? C is a cephalic vein. B is a basilic vein. I remember it from my first year, anatomy DH. One of the residents told us, Madam told us, yes, okay, how to remember basilic cephalic? We said we had no idea. She said that, okay, B comes before C, so B is medial, C is lateral. From that day now onwards, till now, and possibly later on, it will remember like this. Okay, there's also dorsal veins of the hand over here. You can see the thumb side, you can see the cephalic vein, other side, you can see the basilic vein, right? Here, very important regarding the cubital fossa. So there's another topic, guys. I would like you guys to go with it. A very, very famous topic for the exam point of view, cubital fossa. Here in this image, what we are trying to show you all guys, is the roof of the cubital fossa. Okay, we have seen this vein, median cubital vein, the most commonly used vein for any IV access, intravenous access. You have to instill some drug or you have to take the venous blood out. This median cubital vein is the most commonly sought out vein in the entire body. The median cubital vein, very, very famous vein. No, it's a VVIP vein, median cubital vein, right in front of the cubital fossa, that is right in front of the elbow. You have this vein over here. You place some compression in the arm or tourniquet in the arm, where the venous blood is stopped over here, and slightly tap over here, and you'll see the median cubital vein. It is a bit difficult to see in very obese people, but still, you can easily find out with your practice and experience. Practice and experience. Medical line, apart from theory, is practically all about experience. The more you are experienced, the more confident and the better results you will get. Simple as that. Okay, so with the time, always remember the medical branch. With the time, it's going to give you good satisfaction returns. Okay, now in the vein over here, so you can see this basilic vein. Actually, this basilic vein, it continues in the form of axillary vein. Okay, let me just show you like this. This basilic vein, can you trace this basilic vein? It is the one that is continuing into axillary vein. So what about cephalic vein, sir? Cephalic vein lies laterally, but ultimately, it then enters or pours itself into the axillary vein. Understand the form of some rivers. You have a huge river, it has different tributaries. So remember, on a basic point of view, whenever we talk of the venous circulation in anywhere in the body, we talk of the tributaries, because in the veins, the small veins or the venules, they are draining into veins. They are draining into. So we call as tributaries. Like we use the word for rivers. What is the tributary of this river, that river? That is all that water is coming into that river. But when you talk about the arteries, we say the branches, because here the in arteries the blood is going, it is distributing into the branches. So the main artery, the blood in the main artery, it actually will decrease. But in the veins, the blood will increase slowly because it has tributaries. So you can see the cephalic vein also draining into the axillary vein. Axillary vein then continues and becomes the subclavian vein. Remember it. Here, what is this? This is a dissected image. Here you have a muscle. Which muscle is this? This is the deltoid muscle. Okay. And which muscle is this? It is a pectoralis major muscle. So in between the deltoid and the pectoralis, we have a groove over here that is known as the deltopectoral groove. And in this groove, we have this vessel that is running. Which vessel is this? This is which vessel? Question mark. This is our cephalic vein, remember. You can see also in some of the persons who are more physically active or who are going to gymnasiums or who are basically more physically active, you can actually see this vein on the side of the shoulder running between the deltoid and the P major. We have this vein, cephalic vein. And here in this part, you can see that it is entering inside. It is piercing which fascia? The clavipectoral fascia. Previous session, again, eye opener for you guys, clavipectoral fascia. Please, we have discussed in the previous session. The structures piercing it. Mnemonic was CALL. What was the C? The C was the same cephalic vein. So structures piercing the clavipectoral fascia was the cephalic vein. Okay, so remember these points and some of the basic arteries that we have discussed. Now, shoulder joint, guys. This is a must-know topic. I will give it 4 stars. Brachial plexus, I will give 5 stars. So for a topic like brachial plexus, I will give 5 stars. But shoulder joint is no less important topic. It is receiving 4 stars from me. Understand this. Whenever the joint comes, in the previous session also I told you, you have to start with the type of joint, then the bones which are contributing to the joint, then all the capsules and the ligaments that you can think of which contribute to the joint, right? Then what are the movements in the joint that you can think of? What are the various bursas over here? What are the various muscles which causes movements? All entire anatomy should be there in the subtopical format. And finally, associated or collaborated with the diagrams, basically 3-4 diagrams should be there. Finally, we have this clinical applied for any joint. Let me just go through, let me help you go through this shoulder joint over here. Shoulder joint, okay? It is covered by a articular cartilage. You have given labrum. Which type of joint it is? It is a ball and socket. You can see the ball over here. You can see the socket over here. Previous session, I discussed with you guys that the surface area of ball is around 4x than surface area of the socket. Therefore, it is most commonly dislocated large joints. Another thing, let me tell you, forget about the anatomy, theory, and all that. Every part of the theory, listen very carefully, will help you not just in passing the exams. Passing the exams is important for present, but later on, every part of theory of anatomy has clinical importance. And that will help you in your entire life. Remember this. Okay, then you can make this diagram over here. showing us the fibrous membrane of the joint capsule and a bit of synovial sheath over here. Here, the synovial membrane is being shown by this purple color. Okay, so just try to make these diagrams. There's simple shoulder joint with the ball and socket. Next image, understand these are all the ligaments that are being shown with the synovial membrane. In the next image, all the ligaments are shown. In this image, all the ligaments. So ligaments theory wise. So what are the ligaments over here? How to remember? It becomes very tough to remember it. Yes, I know it's not easy. So sir, how to remember it? It's a question. Very good. So we have two bones in formation of shoulder joint. Over here we have a bone that is named as humerus. On the other side we have a bone known as scapula. The scapula has a coracoid process. Also it has a acromion process. Also agreed? Yes, sir. Okay. Whatever you can think of the names connecting them, join them. Like coracohumeral ligament. Let me change the color to show you how we can try to remember coracohumeral. Right? Ligament acromio coracoacromial ligament. Okay, then you can talk of the clavicle acromioclavicle ligament, coracoclavicular ligament. Then we can have glenohumeral. From the glenoid cavity also we have no glenohumeral ligaments. So whatever names are for those bones, we can have the ligaments. Let me highlight over here that you at least try to understand. We have what? We have over here the there are three glenohumeral ligaments, superior, middle, inferior. We have coracohumeral ligaments. Okay. We have coracoclavicular ligament. We have coracoacromial. All these are names, guys. Acromioclavicular ligament. Okay. Then inside itself, the humerus, we have the transverse humeral ligament through which the long head of biceps tendon is passing. It's important. Okay. So you can see coracoclavicular. So you can see all the ligaments are actually covered. Just if you remember what are the all the bones which are associated or which are contributing directly or indirectly to the shoulder joint. There you can remember all the ligaments, simple as that. So don't make it such a big point. Okay, just apply your common sense and things are good to go. Again, you can see all these ligaments over in this image. You should make these diagrams, guys, ligaments over here. Try to, not try. If a question comes off shoulder joint, this diagram should be made. But sir, how we can make such a beautiful, no, who's told you to make exact replica of this diagram? If the scapula over here is going somewhat like this, at least make a scapula having this, okay? Then you can make a coracoid and the acromion. Who is telling you how to make a at least have some basic idea. Then bursas over here, this diagram also, students normally draw it, and if possible try to draw this diagram. It is actually covering all the parts right from inside the glenoid cavity to outside the acromion and the deltoid, whatever is running between them, all the bursas, all the muscles, all the rotator cuff muscles, be it your supraspinatus muscle over here, be it your other muscles like infraspinatus, the teres minor, and the subscapularis muscle over here, all of it. This diagram, try to practice it, guys. But sir, no, but you have to do some hard work, guys. There's no if and but over here. Practice diagrams. Diagrams will fetch you marks. Okay. Then obviously it's a structurally weak point, as we discussed that shoulder joint has more what reason more mobility, and it has less stability. See, let us discuss it, or let us understand from a life's perspective. The people who are more mobile, always roaming from one city to another city to another city to another city, looking for jobs or business, whatever it is, they're obviously less stable. Simple as that. People who are more stable at a particular area, who are particularly more stable, will be less mobile to going to other places for work purposes, not leisure. Leisure, you can go anywhere on all around the world. So anyone who is more mobile will be less stable. Anyone who is more stable will be less mobile. That applies here also. That mobility in our life itself is inversely proportional to stability. If you see the shoulder joint, that is very mobile. Even an obese person, very, very obese person can actually do like this, circumduction. But a very fit person only can move the lower limb like this because hip joint is much more stable than mobile. And shoulder joint has more mobility, it has less stability, simple as it. As it has more mobility, therefore it is more prone to D oblique L is what? It's not your driving license. It is dislocation. More prone to dislocation. Strength of joint is maintained by, we have this all this. So this is all you can write in theory. You have the musculotendinous cuff, that is rotator cuff. Again, guys, in the previous session we have discussed about it. Rotator cuff we have, this is coracoacromial arch, we have glenoid labrum, glenoid cavity outside has a outer lip over here formed of white fibrocartilage. Just to deepen the socket, that is known as glenoid labrum. Deepen slightly but effective. Okay, ligaments, muscle, they all provide stability. Why they have to provide? Because naturally the joint is less stable. So these are all the things that have to provide extra stability so that every person does not have a dislocated shoulder joint. Only few will have, but yeah, still compared to the mole will have. Muscles moving the joint. So you should know the actions of the joints, the flexion, which muscle causes this. I'm not going to discuss the entire muscles over here, but let me just try to show you. I hope this will help you a lot. This is the flexion of shoulder joint. The moment I'm doing like this on the left, in the right shoulder. So all the muscles lying in front are helping in flexion. Remember this meme from Virat Kohli from the Indian tour of Australia previous tour? Okay, so these are all the muscles which are causing flexion. Oppositely, this is the extension of shoulder joint. So the muscles lying on the back are causing extension. This is abduction. So muscle lying over here are causing abduction. This is adduction. So muscle lying towards the thorax, both anterior and posterior, they are causing adduction. This is medial rotation. So muscle lying in front, when they will contract, medial rotation. Understand? Suppose my three fingers are the three muscles lying in the anterior arm. Okay, they are attached over here. Once they will contract, they will rotate my humerus like this, medial rotation. Same or not same, but other three muscles are located on the posterior part of humerus. When they will contract on the posterior part, lateral rotation. This is medial rotation, this is lateral rotation. Flexion, extension, abduction, adduction, combine all of it, circumduction. Circumduction. This is how you should know what are the various. Don't try to cram, guys, these branches. No use of it. First, understand what are the various movements that this joint is offering. Then actually understand the movements. So it is a long, no, it is not a long process. It will hardly take 5 minutes. But then you will remember the muscles for life. Understand the movements. Then try to do those movements and feel the muscles which are tightening. Or in which axis will the muscle lie? On which location? Okay. On which 3D location the muscle will lie. Then if you understood this much, then you have to simply look out for the muscles. Their name, simple as that. Till now, when you feel and you know the axis, your 90% job is done. You know the movement, understand the movement, can feel the contraction of the muscles on which axis do they lie. 90% of the job is done. 10% is the many. Okay, these are the muscles. For example, flexion is this movement. So front fibers or anterior fibers of P major, anterior fibers of deltoid, coracobrachialis, and the short head of biceps. They are all lying anteriorly. Posteriorly, so we have posterior fibers of deltoid. These muscles are lying posteriorly. Look at latissimus dorsi, teres major, tricep. They are all lying posteriorly. Getting a point? Abduction, adduction. So yeah, abduction, adduction. I showed you. Okay, adduction is this movement. The muscles which are pulling the humerus to the thorax, both lying in front as well as back. What are those muscles? P major, latissimus dorsi. These are major muscles. Major muscles are these two. You'll do adduction. Abduction is in itself a separate question. It is initiated by supraspinatus 0 to 15 degrees. So just beginning is done by the supraspinatus muscle located over here. After that, till 90 degrees, so 15 to 90 degree, it is done by the middle fibers of deltoid muscle. Okay. Coordinated movement of deltoid and rotator cuff muscle. 15 to 90 degree. So supraspinatus deltoid muscle. You can feel the tightness of this muscle. Both of your hand, any hand. Right? 15 to 90 degree by the deltoid muscle associated with the rotator cuff. Then after that, from 90 to 120 degree. Understand this. So we are increasing the range of movement over here. Further 30 degree is done by external rotation of the greater tubercle posterior to the acromion. Understand this is a bit more specific, but you have to write this because abduction at the shoulder itself is a separate question. So now 90 degrees this, then more as you do this, you will feel that your humerus is slightly laterally rotating, such that the greater tubercle, what is greater tubercle? It's a bony part in the humerus. It goes behind acromion so that it does not clash with acromion. Slight movement of the greater tubercle, 90 to 120 degrees. Then after that, from further fine 60, that is 120 to 180 degree, that is 60 degrees. Your scapula that is gliding. Now feel the scapula behind, or ask your sibling or your roommate or your friend to do this movement and feel the scapula from behind. In the fine movements, what happens? The scapula over here, it glides around the posterior thoracic wall. And what muscles are involved over here? The trapezius and the serratus anterior muscles. These are the muscles that are involved in the 120 to 180 degree final abduction, because this is 90, that is 180. This is 180. That is the entire abduction from 0 to 180 degrees. So this comes as our separate question in itself. Okay, the abduction over here. And then medial lateral rotation we discussed. These are the medial rotators, the front fibers. These are the lateral rotators, the posterior fibers. This is medial rotation, that is lateral rotation. Remember this. Okay. So shoulder joint in itself comes as a question. Here we are seeing some medial lateral rotation muscles. And the diagram, we have seen this image before. Okay. So guys, this was some of the important topics. I repeat again: brachial plexus 5 stars, shoulder joint we said 4 stars, but again can come as a question, or the various arteries, and small questions like rotator cuff, okay, anatomical snuff box. All these are very, very important. We have discussed them in the previous session. Go through them, please. These are the must-know topics. Okay, I'm still waiting for your question I asked for you guys in the comment box. Let us see this time. A question I asked you, if I do remember correctly, the cutaneous sensation from the which nerve? Axillary nerve, right? Comment box, right? Let us meet tomorrow again to discuss the other important topics from the upper limb. Till then, guys, revise it and all the best. See you soon. Bye-bye.